Thanks again, Professor, and thank you for the invitation. So again, 10-minute talk, a lot of data, 2 decades of work. I'll try to do my best to summarize the salient features. So when is CEA or CAS best? 10 minutes, 5 lessons. First of all, the options for patients requiring carotid revascularization have never been better. Never. The advent of carotid stenting has made carotid endarterectomy safer. If used appropriately in a high-risk patient, rates of complication for endarterectomy should go down. And if used appropriately in the appropriate patient, rates of complication for stenting should go down when the referral to endarterectomy is done well. Carotid artery stenting using filter embolic protection results in more minor strokes than surgery. That's right, I said it. Okay? It happens. And there's reasons for it, it happens. And there's actually some causal scientific basis for it, I believe. I'll show you that in a moment. Endarterectomy causes more myocardial infarction, more cranial nerve injury, and more hemorrhage, and more discomfort to the patient than endarterectomy. And that's true. And we have to reconcile that because it's not an insignificant issue. Randomized trials are a glimpse into the past. Future developments will always address shortfalls, but by the time large randomized trials come out, like CREST, which, by the way, if you haven't been counting, is now 9 years old, it's a historical reference at this point. And a perfect storm will always sink a stout boat in this case being stenting. So randomized trials of supernovas, once evidence they're not really reality, that is, you're only seeing the distant light from a past event. Specific to CREST, the field and the technology have really moved on. The asymptomatic question is now the dominant question. It's no longer whether endarterectomy or stenting are the right ones. Ask any neurologist today and they'll tell you that they care about that, but they care more about the number of asymptomatic patients that are being treated in this country every day. Microembolization, DWI abnormalities seen post-procedure, which are asymptomatic, but which nevertheless are markers of cellular edema and cell death, are more frequent in stenting, except for a couple of exceptions, than they are for endarterectomy. And I believe that this is the link for that minor stroke event rate that we're seeing in stenting. Now, having said that minor strokes are more common, I will say that they don't amount to a long-term deficit. By 1 in 6 months, minor strokes are largely resolved. Nevertheless, they are events we'd like to do better at. The technology, specifically proximal protection, direct carotid access, mesh-covered stents, double filtration, likely represent improvements over all the devices tested in CREST, which remember there's just the AccuNet and AccuLink. Okay, so this is from CREST. I'm going to show you some data more recent. For endarterectomy and stenting are spectacular. All death stroke RMI, and this is like very tightly adjudicated, neurologists saw every patient, that doubles or triples the stroke rate compared to if Chris sees every patient or if I see every patient. So the bottom line is very low rates of complication, and the rates of major stroke are less than 1%. Rates of death, less than 0.5%. So this is incredibly safe procedure with long-term lasting benefit, which I'll show you in a moment. However, as I mentioned before, there are issues around minor stroke and MI, and I'll talk about those in a second. If you look at mortality between the 2 therapies, there is no difference. However, if you look at patients who had a myocardial infarction, which was more frequent in surgery, the mortality was 4 times greater than the patients who did not have a myocardial infarction at 4 years. So it's a marker for death long term. What about freedom from mistral stroke? An incredibly effective stroke prevention therapy, both endarterectomy and stenting. This wasn't known when we started putting stents in people's necks. We knew we were getting rid of the blockage, but we didn't know if we were going to be stroke preventive. And in point of fact, it's incredibly helpful. If you look at this, amortized over 4 years, you're talking about, let's call it for numbers' sake, 3.5%, 4%. That's less than 1% per year risk of stroke in a population whose age is near 70 on average. That's about as good as it gets in that age population with carotid disease. Durability of both procedures is excellent. Out to 4 years, no difference in target lesion revascularization. But there are also opportunities. As I mentioned before, minor stroke rates are about double in stenting as they are for surgery, resolved at 1 in 6 months, but nevertheless, at the time of procedure, more prevalent. and myocardial infarction about double for surgery as it is for stenting. As I mentioned before, there were no issues related to cranial nerve injury with stenting, but there was a 5% 1 month and 2% permanent, if you can call 6 months permanent, it probably is, deficit. And this doesn't sound like a lot, but honestly, if anybody who deals with these patients and sees them in the office, occasionally it's some numbness and some issues with the tongue, but occasionally it's managing your own saliva, and it's not a small issue. Carotid artery access site complications, stenting was very low. Surgical reoperation and hemorrhage was not as low. There's been a lot made about age, and I want to show this FDA analysis. When the data from the CREST trial were presented to the FDA, they do their own analysis on the data. And in point of fact, they found no difference in stroke rates, a primary endpoint over the age of 80. There was lots of talk about that. But they did find a significant difference to the benefit of stenting in patients under the age of 60. So stenting was safer under the age of 60, but no different over the age of 80 or any other age in between. But what was seen, and what's not really well demonstrated here, to the right of this graph, you can see octogenarians have a higher rate of complication regardless of whether or not they're having endarterectomy or stenting. Those complications are different in each bucket. For stenting, it's more stroke. And for endarterectomy, it's more myocardial infarction. So it's not necessarily safer to have an endarterectomy over the age of 80, it's just different. Okay, now Act 1, another randomized controlled trial, very important data set. All asymptomatic patients, stroke death NMI up to 30 days, plus up to 1 year ipsilateral stroke, no difference in this asymptomatic population between stenting and surgery. No difference in freedom from death from 31 days out to death, stroke, and MI, and ipsilateral stroke out to 5 years, no difference. No difference from ipsilateral stroke to 5 years. And look at this, asymptomatic population, 5 years, 2% risk of residual of stroke in the next 5 years. I'll take that number all day, okay, especially if I'm a patient with a 70, 80, 90% lesion. Here are the 5-year outcomes again. Again, there are some opportunities here. Let me go back. If you look at the major stroke rates, no different really, again, less than 0.5%. Major stroke and deaths, about 0.5%, pretty impressive. But minor stroke is about twice, again for stenting, and myocardial infarction was greater for endarterectomy. So let's address these opportunities, and then I'll tell you what I do with my patients stenting or surgery. Minor stroke and endarterectomy, I think, really, stenting, we really have to start taking a cue from this microembolic surrogate, that we call it, and try to understand which therapeutic options reduce that. Because remember, running a trial to show a 1% difference in any therapy we might imagine would be better than the existing therapy would take a few thousand patients. They can't be done anymore. So the bottom line is, look for that microembolic signal. I believe it's a very strong surrogate. Proximal protection results in half the microembolic risk. Direct carotid access, a la Silk Road, with proximal protection, results in endarterectomy-like microembolic risk, so meets the standard of care. Mesh-covered stents, Gore, Scaffold, and MGuard, I'm going to show you in a moment, and double filtration, all have been shown to reduce microembolic hits. Cranial nerve injury, carotid artery stenting with direct carotid access, so surgical access for the surgeons with stenting flow reversal. And MI in endarterectomy, how can we do better? We may be able to pre-medicate with thienopyridines, statins, cardiovascular screening, anesthesia choices. I don't know, but this is a real opportunity. Here's the Scaffold trial. I just presented this data set about a month ago at this Charing Cross meeting. This is the first time it has been shown, and you can see here that for the intention to treat, all stroke was less than 3%, and if we just look at the patients who followed the protocol, all stroke was 1.1%. This is the mesh-covered Gore stent, really showing remarkably improved outcomes compared to historical references. This is the C-Guard mesh-covered stent from Inspire MD. You can see this high-resolution OCT and trap material behind the mesh covering. The CareNet trial actually looked specifically at microembolic signals, and you can see that in this DWI MRI analysis, all patients were asymptomatic. New Upsala lesions were almost a third less in the CGuard as compared to historical references. And the mean lesion volume was actually lower as well. I mentioned the perfect storm. Surgical apposition has been based historically on protectionist grounds. I think that's giving way as we start to improve outcomes. Neurologist opposition has risen as asymptomatic patient focus treatment shifts, and U.S., world, and healthcare expenditures obviously have been problematic. Okay, whether endarterectomy or stenting. For stenting, I choose that for the younger asymptomatic patient, and for the high surgical risk patient, I still believe is a therapy of choice. For endarterectomy, the older symptomatic patient, I believe, probably does better with endarterectomy from a neurologic perspective. And for the patient who has poor carotid stent vascular anatomy, they should go to surgery. And I send more patients to surgery now than I ever have. Stenting or surgery is relevant and good, I think equal choices for the rest of the patients. I would use proximal protection when possible or direct carotid access, mesh-covered stents when they become available, and double filtration when it becomes available. Thank you very much.